Welcome, my fellow questionnaires and quarantiners, to the fifth Q&A webinar here with us at the Latrobe Sports and Exercise Medicine Research Centre. It's fantastic to have you here. My name's Sean Docking. I'm a postdoctoral researcher at the centre. Tonight we'll be discussing a topic that we don't often get the chance to talk about in foot osteoarthritis. Now, first of all, for those who have joined us before, welcome back. But for those who have missed our previous 4 Q&A sessions, don't feel like you've missed out. You do have the ability to go back and see them. If you go to our YouTube channel and search Latrobe SEM, you'll be able to find our channel and all of our previous Q&A sessions, as well as some other content, will be there. You can also go to our blog, which is listed here. Not only can you see the videos, but you'll also be able to see the papers and citations of some of the papers that we discussed during the Q&A session. Also, if you haven't done so already, make sure you follow our Latrobe Twitter page and our Facebook page. So enough with the plugs. I'll stop sharing my screen now. We are very happy to have with us tonight Professor Hylton Menz, who is a director at LACEM and also a senior NHMRC fellow investigating musculoskeletal foot disorders in older individuals. He graduated podiatry at Latrobe and then went on to complete his Ph.D, I should say, in 2002. His research covers everything from prevalence to biomechanics and rehabilitation of foot problems. And he has won several awards, including the Young Tall Poppy Award, and also he's a Fulbright Senior Scholar. So, Professor Hylton Menz, thank you so much for joining us tonight on our Q&A.
Thanks very much, Sean. Good to be here.
So, I've got to probably cover the thing that's it's as obvious as the beard on your face. It's the beard on your face. This is a recent addition for yourself. Any particular reason for growing this?
No, it was purely a COVID-19 induced sort of ISO beard thing. As soon as I got sent home from work to work from home, it started then, and it just keeps going. So it is where it is after by 4 months or so of not shaving. So that's what happens.
So in the 4 months of your new relationship with the beard, what's the most annoying part about it? We sort of had a quick discussion about maintenance. Is that it, or is there another reason?
Mostly face masks. Since we've had mandated face mask wearing in the last few weeks, it's been a bit of a challenge, particularly if you're going for a run. It's not that pleasant.
A very COVID issue at the moment. And I suppose the other topic that a lot of people are asking on social media is it here to stay?
Well, I said I was going to shave it off when I got back to work, but given the way things are headed, that might be a fair way off. So I might be tripping over it by then. So no, I think its days are probably numbered, probably a bit shorter than that.
Sounds good. All right. So before we get into asking you some questions about Foot OA, I just wanted to do a little bit of housekeeping. So what I'm going to do is I'm going to take the host's prerogative and be able to ask you a couple of questions for about 5 or 10 minutes. And then we open it up to you, the participants, to ask your question. Now, the way to do that, if you haven't used Zoom webinar before, is you'll see a Q&A button at the bottom of your screen. Make sure you click on that, include your question. There is also the ability to upvote questions. So if you see a question that you really want Hylton to answer, then make sure you upvote it, and we'll be able to see it in the top of our list. Also, if you do put your name down for a question, have your microphone ready, because it's more than likely going to come to you to get you to directly ask your question rather than me bastardizing it in some way. So, Hylton, you recently published a review with Ed Roddy from Keele University around Foot OA. it's a really interesting topic when we started discussing this, because it is frequently neglected by the research literature, but it is quite a prevalent problem. I was hoping you'd be able to discuss some of the differences in osteoarthritis at the first MTP joint compared to the midfoot, just around sort of the differences in the prevalence and also sort of its clinical presentation.
Yeah, it's a good place to start, actually, because we talk about foot OA broadly, but it really does separate quite nicely into two main phenotypes. And that was driven by some work that was done at Keele University in the UK, where they had a really nice cohort study there, looked at osteoarthritis changes in multiple joints and applied some pretty clever statistical models to work out where they sort of clustered. And what they found was that there are these two pretty clear-cut phenotypes, the first one being osteoarthritis, which is limited or isolated to the first metatarsobaphalangeal joint. And then the second form is more of a polyarticular form of OA, which tends to cluster around the joints of the midfoot. So I'll probably refer to that as midfoot OA as we go on, just to make it nice and clear. So the good thing about that is that it sort of simplified a fairly complex multi-joint presentation, but also because it matches up with what you see clinically. People do come in complaining of a sore big toe, or they come in complaining of a sore midfoot. And these conditions, even though they're both forms of foot OA, they do have different risk factor profiles, and they do obviously require different approaches to treatment. Now, if we look at so the risk factors, for example, even though both of them are more likely to occur in women, they're both associated with age. First MTP OA tends to be more of a sort of a structural deformity where the underlying sort of morphology of the bones of the first ray, the first metatarsal and proximal phalanx, do seem to drive a lot of the biomechanics that's happening with the first MTP. Whereas midfoot OA is a little bit more nebulous. It's a bit more metabolic. It's associated with things like obesity and also associated with previous injury. So they are quite different conditions.
That's great. And I think it's sort of important for us to highlight, because I think I've heard you previously talk where in the foot, you're talking about 35 different joints and that sort of its impact around osteoarthritis. But you generally, in a lot of the research at this point, it's confined to 5 or so joints. Is that correct?
Yeah, so how that happened was, it's obviously with the foot, you're dealing with lots and lots of different joints that could all conceivably develop osteoarthritic changes. Now, when we first started researching foot OA, there was a real gap in the literature in that there was no standardized way of assessing or sort of defining whether someone had foot OA. So we had to go and develop our own radiographic atlas for that purpose. And when you're developing an atlas, you need to be fairly pragmatic in that you don't want to have to get everyone to go out and get multiple radiographic views to identify osteoarthritis in these joints. So we limited it to an AP or a dorsoplantar X-ray and a lateral X-ray. And that's because they're the views that most people will order in clinical practice. And in doing that, though, that did limit the number of joints that we could really include in the atlas. We selected mostly sort of medial midfoot joints in addition to the first MTP, partly because they could be easily visualized with those two radiographic views, but also because we had a sense that they were the joints that probably most likely affected by OA. So it was a pragmatic decision, and it does mean that the prevalence estimates that are out there for foot OA are all underestimates, because there's bound to be OA in particularly, say, the lateral column joints around the calcaneocuboid, and also within the interphalangeal joints, which don't contribute to the atlas. So we did end up settling on these 5 joints in the foot, and a lot of the work has stemmed from that atlas with that limitation on the 5 joints.
That's brilliant. And Matt's been able to put the link to that review for those who want to go find it. Now, you sort of talked about, obviously, the differentiation between first MTP and midfoot OA is obviously pain location. But is there any clinical or battery of clinical tests that are useful for diagnosing these conditions from other conditions that might present in those anatomical locations?
Yeah, well, if we go through first MTP OA initially, obviously your differential diagnoses there need to be things like your inflammatory arthropathies, your rheumatoid arthritis, your crystal arthritides like gout, that sort of thing. But once you've excluded those, it then comes down to sort of clinical observations. Now, we developed a little diagnostic test battery a few years ago. We had a group of people who all had some first MTP pain. We x-rayed them, worked out who had radiographic OA and who didn't, and then set about seeing whether we could sort of diagnostically determine whether someone has underlying radiographic OA with some simple clinical tests. And what we found was using 5 tests or 5 observations, the first one just being whether the patient has had pain for more than a couple of years. Then you look at whether the patient has dorsal exostosis, so large bony lump on top of their foot, limited joint range of motion in the direction of dorsiflexion, crepitus during that joint range of motion, and also a very hard end feel to range of motion, so a bony block. Now, out of those 5 observations or tests, if you had any 3 of those, you can be pretty much certain that that person has radiographic osteoarthritis. So really anyone that comes in, if they're in the right age range, they've got a stiff big toe, the pain's sort of isolated to the toe joint, and it's got a very limited range of motion, you can be pretty confident. Now, it gets a little bit trickier with midfoot OA though, unfortunately. A similar sort of study was done at Kiel trying to work out whether clinical observations could identify radiographic changes, and unfortunately it wasn't as easy as the first MTP. We know that it's associated with obesity, and also there's a tendency for people with midfoot OA to have flatter feet, and Merridy will talk about that a little bit later on. But those associations aren't really strong enough to be diagnostically useful. You can probably rule out OA, but you can't confidently rule it in with the midfoot. And so I think it's probably the case that the midfoot is also just, it's a region where a lot of other things can happen. There's a lot of other conditions that aren't OA that can result in pain in that region. And midfoot pain does tend to be fairly diffuse and fairly vague. So in terms of imaging and things, even though you probably don't need any x-rays to diagnose first MTP OA, there could actually be an argument that it may be helpful for the midfoot.
That's great, and there's a lot of fantastic clinical tips in there. And I suppose it's going to be a common theme that even though we sort of started talking that foot OA is a neglected condition, when we start to get into the midfoot and talking about osteoarthritis, there's even less in the literature sort of helping us and guiding us in there. One of the, maybe this is just a quick overview because it is quite a broad question, but in terms of managing these conditions, where is the literature pointing us at this point? Is there any sort of gold standard primary care for these conditions, or are we not there yet?
It's probably safe to say we're not there yet. In terms of randomized trials, for first MTP OA, you're only looking at 5. We're updating a Cochrane review at the moment. We published the first one back in 2010, and there was a single randomized trial, and there's only been 4 additional trials since then. So there's not a big body of evidence that we can draw upon. And then there's even less for midfoot OA. There's quite a few sort of case series studies, but there's only really one very good pilot RCT by Jill Halstead's group in Leeds of foot orthosis for midfoot OA, but there hasn't actually been a fully powered randomized trial for midfoot OA yet. So because of that, there's really no sort of consensus guidelines about how you should manage foot OA. There's been some interesting work done by Kate Patterson at Melbourne Uni. He's looked at how GPs manage foot OA, and it's essentially managed pharmacologically, mostly with the use of NSAIDs, followed by referral to either an orthopaedic surgeon or a podiatrist. And Cade's also done a survey of how podiatrists and physios are currently managing foot OA. And they're the usual sorts of things that you would expect to see. So podiatrists tend to do more in the way of foot orthoses or footwear advice, whereas physios are more likely to do exercise interventions. But the actual evidence that's underpinning that is really limited.
Certainly a lot of scope for anyone who's wanting to do any further research in this area. Now, going to some of the questions from our attendees and also online previously. So make sure you get in your questions, guys. We'll be coming to you soon. But one that we had that came up a couple of times when we were promoting this event prior was a question about why do people present with more pain or more severe clinical symptoms in midfoot OA versus first MTP. So first, I suppose, is this true? Do you commonly see a more clinical, greater clinical severity in that midfoot OA patient? And secondly, do you have any explanation of why that might be the case?
Yeah, look, that's a good question. Look, I'm no longer in clinical practice, so I might refer to my clinical colleague, Merridy, to sort of touch on that later on. But certainly in terms of the sorts of people that are involved in trials that come in, first MTP OA does tend to be this fairly vague, sort of dull, aching sort of pain on presentation. Whereas there is some evidence that midfoot OA also presents like that, but it can also be intermittently quite sharp pain. And it could be that maybe midfoot OA is more susceptible to flare-ups than first MTP OA. There's no other sort of physiological reason why I could explain why midfoot OA may present as a more painful condition or a more sort of severe condition than the first MTP, but there does seem to be the case that this sort of intermittent sharp pain occurs in midfoot OA, but to a lesser extent in the first MTP.
That's great, and it's probably a good time for us to introduce Merridy Lithgow, who, apologies if I got this correct, but is a PhD candidate. Currently looking at midfoot osteoarthritis. So Merridy, first of all, welcome. Thanks for being here with us.
Thanks for having me.
Great. Now, I think this is a great question that we got online, which is right up your alley. I was wondering if you could help sort of discuss some of what are the functional deficits or differences that we see in individuals with midfoot OA.
Yep, so we've just recently published a systematic review looking at the differences between foot structure and lower limb function between people with and without midfoot osteoarthritis. So in the review, so to be eligible, studies need to include a group of people with radiographically confirmed midfoot OA and also have a control group of participants without midfoot OA. So there was 11 articles which we found that met that inclusion criteria. And what we found was that individuals who had midfoot OA, they had a more pronated foot posture. They had that greater first ray mobility. They had less range of motion as well in the subtalar joint and the first metatarsal phalangeal joints. They had longer central metatarsals, so 2 to 4. And they also had those increased plantar pressures and contact times in the heel and a midfoot. So yes, there was definitely several differences between people with and without midfoot OA.
That's really interesting, and sort of you said it was recently accepted, so congratulations on that.
Thank you.
Now, I was really interested on that finding about individuals with midfoot OA having a more pronated foot. Is that potentially a target for treatment either through orthoses or some other method in the future?
Yeah, definitely. So I think one of the most sort of consistent findings of the studies included in the review were that, that midfoot OA had that more pronated foot posture. and they were looking at sort of clinical measures and radiographic measures. So, I think these findings sort of support the view that, a more pronated foot posture may result in sort of increased increased compressible forces in the medial midfoot and could lead to midfoot OA. And this has also been consistent with cadaver models that, simulate that flat foot. You have that increased dorsal sort of joint compression in the midfoot. So, from the review, we've found that due to the cross-sectional nature of the studies that were included in the review, we're unable to say if, this is a cause of midfoot OA, but it is biomechanically plausible. So, does this provide a potential target for treatment? I would say, yes. So whether we're looking at supporting that pronated foot during gait with an orthotic design to invert the rear foot and, support the MLA. But yeah, currently there's very sort of limited evidence out there for the treatment options for midfoot OA. And as Hylton's already mentioned, there's only one pilot RCT, which is looking at orthotics versus sham orthotics. And they did find improvements in pain at 12 weeks. But yeah, I think there's still like a lot more to learn about sort of the baseline characteristics of people with midfoot OA, because currently there's not much sort of baseline data to tell us what people with midfoot OA look like while they're walking. So I think, once we sort of do further research into the kinematics of how these people with midfoot OA are walking, I think then we can sort of target, more specific custom orthotic therapies and footwear and exercise prescription.
That's brilliant. Can't wait to read the paper when it's finally published. Now we're going to go to, he's almost my second host for a number of times we've gone to him with all these fantastic questions. So Hamish Ashton, Hylton spoke about his imaging atlas and the use of x-rays. And your question relates to that.
Hi guys. Yeah, I've sort of enjoyed these very much, so thanks for doing them. My question sort of about looking at the OA aspect of things radiologically. With lower backs now, we're told don't bother taking x-rays, especially if the person's older, because we're going to see some OA changes in it anyway. Is that sort of the same for the foot, especially the midfoot region? And, what likelihood, if we take an x-ray of it, means that if we see the OA, it is actually related to the symptoms that they present to us?
Yeah, it's a really good question. And if you look at some of the work that's been done looking at radiographic OA, so as opposed to symptomatic radiographic, just looking purely at radiographic changes within the joints over a very wide age range, you do notice a very, very strong sort of linear increase with age, with different radiographic changes within joints of the foot. I guess the point with the that I made with midfoot OA is that if you have someone coming in who has midfoot pain, as opposed to say knee pain, where you can sort of say, well, if someone's of a certain age and you've ruled out other conditions, they're pretty likely to have knee OA, so maybe you don't need to send off for an x-ray. For the midfoot, I think it's a little bit too vague for that. I think you can't really assume that someone of a certain age with midfoot pain has OA. Now, I'm obviously got my sort of research hat on with this in that the X-ray atlas is really useful for identifying a case definition of symptomatic radiographic OA. Now, in clinical practice, it would be really good if you could do something similar to what we did with the first MTP and say, okay, if someone has a flat foot, if they have limited motion in the midfoot, they're of a certain age and the symptoms have been there for so long, then you don't need to send off for an x-ray. And definitely some more work needs to be done in that regard. But the midfoot's really tricky, particularly in terms of doing clinical testing on, because it's really hard to get a decent measure of midfoot range of motion, for example, compared to the first MTP. So we are at a point now where we really can't just sort of assume that someone with any sort of midfoot pain has OA. Now, that doesn't mean I'm recommending you go off and send off for x-rays all the time for this, but it does mean that we need to do a lot more work on trying to work out a clinical battery of tests that might be able to be diagnostically useful in identifying the condition.
Thanks, Hylton, and thanks, Hamish, for that question. I think this brings up a really good point, and we frequently talk about sometimes osteoarthritis being this catch-all term, but there are commonalities, but there are differences in osteoarthritis between different joints. And I suppose with some of Adam Colviner's work on his systematic review about the prevalence of incidental findings in knee osteoarthritic findings is an example of that. Is there any other differences that you commonly see in, or that you have found in your research or clinical experience between knee osteoarthritis and osteoarthritis at the foot?
Well, probably in terms of risk factors, they obviously share quite a few risk factors in terms of age, obesity, more likely to have it if you're female rather than male with foot OA. But probably the main difference in terms of risk factors for the foot would be there's actually a much stronger association between occupational factors and foot OA than there is for OA in other joints. So the way this gets approached in these cohort studies is to look at an occupational category of being manual or routine. So people who spend a lot of time on their feet doing sort of manual tasks as opposed to, you know, sitting down in an office or having another sort of professional role. And that's very strongly associated with both first MTP OA and also midfoot OA. And when you think about it, it does make a lot of sense that if you are exposing your foot to this very cumulative sort of long-term load as a result of your occupation, then you're more likely to develop osteoarthritis in the joint. So even though the risk factors do overlap between foot OA and OA in other joints, the contribution of occupational factors is a bit stronger.
That's great. And now we'll go to Rowena, which I think this might be a question for you, Merridy. And you had a question about the role of manual therapy.
Hi, thank you very much for the presentation, all three of you. Yes, so I was wondering whether manual therapy had a role here, or was it primarily exercise and rehab prescription? And if so, I guess it's a second question. What are your top 3 rehab exercises, particularly for the midfoot?
Yeah, in terms of what evidence is available for manual therapy, there's not a huge amount for the midfoot or the first MPJ. There is one study looking at the first MPJ, looking at sort of exercise prescription. And so they found sort of sesamoid mobilization, flexor hallucis longus strengthening, and gait retraining was more beneficial in first MPJ OA compared to physiotherapy alone. So I think that's probably the only study that I've seen for treatment in or evidence-based in sort of that manual therapy area. And yeah, for the midfoot, unfortunately there probably isn't there yet. I don't know, Hylton, if you're aware of any, but I don't think there's any at the moment.
No, I'm not aware of any trials. It's probably worth mentioning John Arnold at Uni of South Australia has done a really nice bit of work just recently looking at strength deficits in midfoot OA. So he looked at midfoot OA cases and controls using handheld dynamometry, and he did find some pretty marked strength deficits in the OA group. Particularly with muscles responsible for inversion. Okay, so even though it's a cross-sectional study, we don't know whether the weakness preceded the OA or whether the OA led to the weakness. It does certainly open up the possibility that there could be some benefits in conducting strength based interventions for midfoot OA, but I'm not aware of anything that's been published in that area. The only other addition I'd say in relation to the first MTP is there's a little bit of stuff out there in terms of manipulating the joint under local anaesthetic. The idea here that you do an intra-articular injection of a combination of cortisone and local anaesthetic, and then while it's anaesthetized, you sort of put it through some manipulations to try and free up some of those adhesions. There's a couple of studies on that. The results aren't fantastic, but they do seem to be beneficial, but only in the sort of early stages. Obviously, if you've got a joint where there's a lot of joint space narrowing, a lot of osteophytes, you're not going to get much benefit out of trying to manipulate a joint like that. But that's sort of the extent of the evidence as it currently stands. There's really not much out there at all.
Thanks, Rowena, for your question. That was great. Merridy, I suppose it was just to follow up on that. With sort of a patient coming to you in your practice, I believe that you still practice as a podiatrist. Are you just looking at orthotics, or do you employ some of your some manual therapy techniques or prescribe exercises that maybe the literature doesn't give us any guidance on yet, but you find is helpful in your practice?
Yeah, definitely. So I think probably in terms of I'll definitely look at sort of some strengthening of the lower limb, and then sometimes like giving intrinsic muscle strengthening as well. Yeah, I think with manual therapy, I think, we try a little different treatments for different people, and I think some work for others, some don't. So, yeah, I definitely sort of use a combination of exercise prescription and orthotic therapy. So, yeah, I find that can be quite successful, especially in those quite painful sort of rigid feet sometimes. But, yeah, I use that along with orthotics as well.
That's great. So I suppose just to follow up on that, you mentioned sort of doing some general strengthening exercises for the lower limb. Are you primarily targeting the calf complex, or is it a general lower limb strengthening program?
It really depends on what they're coming in with. So I think, specifically depending on what pain they have, they may need some sort of proximal strengthening as well. Looking at some sort of some flexor hallucis longus sort of strengthening exercises, and just looking at inversion, eversion, dorsiflexion and plantar flexion. Again, as sort of Hylton's already mentioned, there are some deficits in these patients. So, yeah, looking at strengthening sort of those muscles as well.
Brilliant. One of the topics that was brought up in your review, Hylton, was around surgery as a potential option for treatment of foot osteoarthritis. And there seems to be this dichotomy of techniques of joint preserving versus joint destruction. I'm sure the literature isn't giving us any insight into one versus the other, but I was hoping you could share some of your thoughts and insights on those two different surgical approaches.
Yeah, well, for the first MTP, you've got a few options available surgically. Probably the simplest approach is a technique called a Kylectomy, which basically just involves removing that dorsal exostosis to free up the joint range of motion. So obviously that would be a procedure that would be used in a relatively early stage. So that's joint preserving. And then there's sort of something in between joint preserving and joint destructive called interpositional arthroplasty, where they sort of use the dorsal capsule and then bring that through the joint to still sort of produce a pseudo joint so the joint can still move, and then all the way through to fusion to arthrodesis. Now, as with a lot of the surgical literature, it's mostly case series studies that you'll see, although there was recently a randomized trial. It's the only randomized trial that's been published that was comparing a device called a Cartiva implant, which is like a sort of an artificial cartilage implant, which goes in the joint itself, and they were comparing that to arthrodesis. And it was a sort of a non-inferiority trial. It was basically seeing whether the two were broadly sort of equivalent, and they essentially were. So the idea behind that, though, is that it does enable you to still have a functioning joint. Now, they've tried a few different joint replacement procedures over the years, like you would for a knee replacement or hip replacement. It doesn't work particularly well in the big toe joint. You tend to get a lot of prosthetic loosening, and a lot of the early attempts to try and replace the joint haven't really worked that well. Now, I'm not a surgeon, but broadly speaking, looking at the literature, it does seem to be the case that the younger, more active patient is more likely to have something like a kylectomy, a joint preserving technique, whereas an older person or a more sedentary person is more likely to have an arthrodesis. Now, for the midfoot, there's not as many options available. It's essentially a fusion of those proximal joints. That's obviously a fairly major procedure to have done, and does have some consequences in terms of the way the foot functions afterwards. So even though there are a range of things you can do for the first MTP, for the midfoot, it is largely limited to fusing the affected joints.
Oops, getting the mic on. That is great. So one of the questions that we just had come up as a result of this discussion about surgery and the different options, at what stage are you starting to consider surgery as an option? Is it really this end-stage disease based on their clinical symptoms or radiographic findings? What are the sort of factors that come into that decision-making?
Well, I guess it would come down to a whole range of different things. It wouldn't obviously just be driven by the radiographic appearance. It would depend a lot on the activity level of the patient, that sort of thing. I do recall we had a participant in one of our trials where we were actually looking at Rockasol footwear and foot orthoses for first MTP OA. Is one of the younger participants that we'd had, who was, I think he was late 20s, who was very active and was getting a lot of pain associated with his first MTP OA. He ended up opting to have a kylectomy, to have the surgery to have the dorsal exostosis removed, rather than pursuing the rest of the trial that we were doing with our footwear and orthoses. So obviously it depends on each individual patient's sort of needs, but in that case, it was an example of someone who was very active. They didn't want this to stop them. They didn't really want to muck about with conservative interventions. They wanted to go straight in and get it sorted out. Now, at the other end of the spectrum, of course, if you've got someone who's got a really advanced first MTP OA, that the joint's just not moving, you've trialled orthoses, shoe stiffening inserts, you've trialled Rockasol footwear, and you're not getting anywhere, then obviously that would be a candidate who would probably benefit from having a surgical assessment done.
That's great. Merridy, anything from your clinical experience about that sort of decision-making around when to refer on for surgical options?
Yeah, I think probably it's really when you've tried everything and you're not, all your conservative treatments haven't helped resolve. So it tends to be definitely in that later OA stage where, you know, you've tried, you know, with orthotics, you know, if that's not working, you've tried to, you know, lock up that joint to reduce that range of motion. And then it's probably at that point, once you've tried most conservative options, is when I would refer on.
That's been brilliant. And thank you both for being part and answering all our questions. I suppose my last question to wrap all this up, we've covered this a number of times, mentioned it a number of times, Hylton, and I think in the paper you discussed that it's sort of 1 in 6 individuals over 50 have or suffer from foot OA at some point in their life. But there is an absence of literature or research helping us guiding diagnosis, treatment, and the factors. So we're going to give you 3 wishes from a genie. what are these sort of the three main priorities do you think that we need to focus on as clinicians and researchers to better understand this condition, and also make sure that we can limit its impact on individuals' quality of life?
Look, probably the first one from a very research-focused perspective is with anything around OA, it would be really nice to have good prospective data with, radiographs and patient-reported outcomes over a very long period of time, because you're dealing with a condition that does take a long time to develop, and some people progress, other people don't. It would be really nice to really fully understand what's happening in terms of, I guess, the natural history of the condition. And a colleague of ours, Kathy Bowen at the University of Southampton, has published a really nice paper that's in the current issue, actually, of Arthritis Care and Research, where she looked at first MTP OA in a large sample of older women over time and answered some of those questions around progression. But in order to really work out what's going on, particularly with midfoot OA, Merridy is going to tap into this for a PhD. We sort of talk about midfoot OA being associated with flat feet, but that's sort of as far as we go with that, and it's not really enough. We sort of need to know what exactly is going on and how does the flat foot or pronated foot function dynamically actually contribute to the radiographic changes in the symptoms. Sort of making that connection there is a really important one, because that's how you start to understand how interventions can actually be disease modifying rather than just some things that change symptoms through all sorts of other contextual effects. So ultimately this comes down to research funding, and we've tried hard over the years to get some funding for these projects. We've had some success. We've been very fortunate to have 2 randomized trials funded by the NHMRC that are focused specifically on the first MTP. So you wouldn't normally think the NHMRC would be interested in big toes, but they've helped us out with that along the way, which has been great. But obviously in a field where there's only 5 RCTs for the first MTP and 1 pilot trial for the midfoot, obviously there needs to be a lot more investment into clinical trials to fully understand what's going on, so we can manage the condition a lot better in clinical practice.
That's great. And I'm sure that sort of prospective data of the impact and its sort of impact on individuals' quality of life is really important for making that case. So we're going to end it there. Hylton, Merridy, thank you both so much for sharing your amazing knowledge and expertise. It's been certainly quite eye-opening in a lot of sort of the similarities and difference between osteoarthritis at the foot and other joints. So thank you again.
Pleasure. Thanks for having us.
Great. So, and most of all, thank you to all the attendees and your fantastic questions during these sessions. We hope you guys find these enjoyable and useful. We will continue to try and run these into the future. So like I mentioned at the start, make sure you follow our social media channels and check out the blog for a number of other resources around all the different things that we research within the centre. So at that point, I will say goodbye. Thank you all very much for attending, and please be safe. Talk to you later. Bye.